All right, hey guys, I'm joined with Jay Paisley of Crisis Application Group. Say hey, Jay.
Hello, hello.
Hello, he did it. Jay runs a tactical training company. They do all kinds of stuff. Medical is his real forte, but you also do some other stuff. What do you do?
We like to teach marksmanship. We do some survival training, mostly guided survival tours, and we do some communications training.
Fantastic. I'm up at his property. He's hosting a pistol and rifle class for Warrior Poet stuff. So thanks for hosting me. And in the meantime, I wanted to talk with the medical stuff. Jay was in the military for 20 years. 15 of those years were in SOF. He spent, and tell me if I nail something wrong, 5th group. He was in 18 Delta, and then went on to do some Tier 1 stuff in North Carolina. Is that right?
That's right. About half my career is in 5th group, and the other half of my SOF career is going to be at Fort Bragg. That's
awesome. Cool. Hey, as a bonus for you guys, y'all have seen me go through some of my medical kits, and I was an EMT in Ranger Battalion once upon a time, and I am way out. And so what I thought would be fun is, one, we just tap into Jay's medical expertise. He's going to go through some of my kits that I've talked about, really just the individual components, and say, hey, this is good, this is bad, make some recommendations, and then we'll kind of go from there. Sound good?
Sounds like a plan.
All right, very good. So let's see just kind of basic stuff.
All right, so anytime I'm dealing with an IFAK or a bleeder kit, I try to go categorically down the MARCH assessment.
Yep.
It's a good way to keep me organized, and it's also a good way to make sure I didn't miss anything essential. So instead of trying to figure out, did I have a tourniquet or do I have an airway, I go down MARCH and I make sure I have an item for every aspect of that. Yep. This way I have everything, not just for one injury, but for the entire TCCC protocol based on my scope of practice.
Cool. And what's TCCC, and why should I care?
Tactical Combat Casualty Care is what I like to call the military trauma model. It's what's got us engaged with using tourniquets and being very aggressive with bleeding control. And it's over the last few years, it's spilled into the civilian sector. Law enforcement and EMS may be familiar with the TCCC, Tactical Emergency Casualty Care, which medically speaking is about the same.
Okay.
However, it uses more relative operational experience in the language. But in terms of the medical stuff, it's about item for item the exact same thing. TCCC is kind of the overarching term we use as civilians, or really in the tactical industry, that kind of encompasses everything. But specifically, when I say Tactical Combat Casualty Care, I am utilizing the military trauma model as my guiding force, if you will.
Very good.
So both TCCC and TECC, military and law enforcement, use MARCH. It's an acronym to keep you organized. It stands for massive hemorrhage or bleeding, airway, respiration, circulation, and hypothermia head injury. The idea is if you Googled trauma and or trauma skills, you're going to get hundreds of millions of hits. And the idea behind MARCH is to organize the infinite knowledge that is tactical medicine and trauma medicine into an easy to understand, easy to implement methodology when you're under stress and you're under-resourced. So TCCC has been proven now 10, 15 years at least, if not longer if you go back in the data. So it is substantiated through the numbers. It's good stuff. We can show you on paper this does work, even if you're not comfortable with the necessary particular procedure. Same thing goes for TECC. They use MARCH also, and for the law enforcement EMS guys, they work in a highly litigious operational environment, so making sure that they're covered and trained and they have that latitude to make difficult decisions in difficult circumstances is very important. So for those of you out there who aren't familiar with TECC, please get familiar with it if you're a civilian provider or responder.
Let me muscle in. Jay was on the board of TCCC, so just deep resume. Can I say that?
Yeah, absolutely. Yeah.
Okay,
so my experience with TCCC as serving on the committee as one of the enlisted advisors gives me a unique perspective on the tactical medical stuff, largely because I was around when we argued in favor of or against certain procedures in certain circumstances. So rather than focus on exclusively what does this device do and how does it relate into a clinical setting, we could take into account factors like my ability to train a lot of medics. An example I would give is intubation. Right, it's sticking a tube with a bulb down somebody's trachea so that they can breathe. In a classic tactical medical model, you don't see a lot of intubation because we have decided, not that intubation is bad, in many cases it's the absolute gold standard, it's that I can't reliably train 10,000 medics how to intubate and keep them current in the field.
Yeah.
So
in the dark, bullets
in the dark,
flying,
bullets
medevac.
flying,
It's
in a
just not
helicopter.
feasible.
It's not a feasible skill for us to reliably implement over time. However, if you can innovate and you're good on your skills and it's within your scope of practice, if you could, by all means do it. And that's where I kind of like to interject a little bit of experience. I hear oftentimes from a criticism standpoint that myself or one of my students may have performed a skill that's not TCCC approved. And that's when I have to remind them, well, TCCC is a guideline. It's not a protocol. You can completely vary from it. And if it's within your scope of practice to perform the procedure, have at it. Right?
That's cool.
So TCCC and TECC is as often as we use it in the language, I like to remind folks it really is the lowest scope of practice out there.
So what if I had a tourniquet that was not TCCC approved?
Well, I think there's room for non-TCCC approved tourniquets, and I realize this is the hot topic or hot button topic in the medical community. TCCC up until recently, really this year, has had two primary tourniquets that is considered approved. And we have one example here. We have cat tourniquet. This year they released a couple more tourniquets, and that's good. It gives you a little more versatility as providers. But I do think non-TCCC approved tourniquets, there's certainly room in the medical discussion, especially in the continental United States, where we have access to reasonable follow-on care. That's not to be expected in expeditionary medicine, say in the military.
Okay.
So having a discussion around, say, the RAS tourniquet or the SWAT-T in the civilian setting is a good thing. It's not really going to work in the military setting because the expeditionary medicine requires relevant operational experience. And again, getting back to the difference between TCCC and TECC, I see room for non-TCCC approved tourniquets in the TECC dialogue. Okay. When if I was a SWAT official and I'm looking at my paramedic, yeah, certainly I can reliably hand them off to a higher scope of practice. Does that make sense?
It does. That being said, of the viewers who aren't all 18 deltas and can say, you know what, I see the guideline of TCCC, but I'm going to follow my own protocol kind of thing. Of really, what's some good advice for the viewers of, hey man, what should I get? What should be in my EDC bag? What should be put in my bleeder kits or my IFAKs on my vest or belts? You kind of take us through what to go. And first off, since we mentioned tourniquets and you're holding shears, what are kind of, give us what we've got in front of us, and then maybe if you have something else, like, you said a SWAT-T or something.
Sure.
Whatever you think is good, go ahead and give them some wiggle room so they don't have to necessarily buy that exact same thing. What if they have something different?
So, generally speaking, as a matter of preference, I prefer the cat tourniquet, largely because every time I reached into the tourniquet bin back in work, the cat tourniquet was there.
Okay.
If somebody was to use a soft T wide tourniquet, I'm cool with that. I've used the soft Ts, I've used the old soft Ts, the new soft Ts on patients. They're excellent tourniquets. As a matter of preference, I'm going to default to the cat tourniquet. So generally speaking, if I don't know you and I don't know what your capacity is, I'm going to tell you stick to the TCCC approved, not that there isn't room for discussion, but we know when it comes to the TCCC approval, the data is going to be back there. That's going to cover your 6. If between your discussion and my discussion, there's a lack of training on your part, if you just stick to that guideline, not that there's not other options, rest assured the data is going to be there to back you up if you get called to task on why you did something.
Gotcha.
So if you look at wounding patterns, and wounding patterns as a whole are a tricky subject also. Remember, when it comes to tactical medicine, not trauma medicine, tactical medicine, we are concerned with what we call preventable death. Not all death. If you just Googled what the #1 cause of death on the battlefield is, you're probably going to get some variation of uncontrolled internal hemorrhage or uncontrolled, brain injuries of some kind. We can't prevent those deaths.
Yeah.
What we can prevent are extremity hemorrhages. To some extent, what we call junctional bleeders. Those not quite extremities, but just too high to get a tourniquet on.
Yeah.
We have some influence over the outcome of those wounds. Same thing with chest wounds. These are simple treatments that we can do. This is based on wounding pattern. So we know a vast majority of the time, the #1 preventable death on the battlefield is generally uncontrolled extremity hemorrhage. Preventable death. That's how we qualify that. Second's going to be some type of chest injury that results in what we call a pneumothorax, tension pneumothorax, or classically collapsed lung. Okay. and then finally some type of airway compromise. Again, there's a lot of variations you can have in the injuries, but what we see repeatedly, thanks to body armor, tactics that are in place in the tactical community, right down to how they approach the bad guys, it does affect the wounding pattern. So you would expect to see wounding patterns, say, in a civilian population to be a little bit different than in a military population. But if we get back to the root word, preventable, a preventable death on a civilian population, by and large, isn't going to be much more preventable or less preventable than a military population. The fact that I'm a soldier and wearing body armor has no bearing over my physiology. My body, I have a heart, I have blood, I have a brain like everybody else. It's electrical or plumbing. It's that simple. What can I do within my scope of practice to affect that? So the easiest thing I can tell folks to do is get and carry some type of tourniquet.
Okay.
All right, so the cat tourniquet and the soft T wide, certainly data proven. They got the history behind them. The folks who are experienced will tell you they're great tourniquets to use in a highly stressful, environment.
So when you say carry those, you mean for the normal civilian as well? I mean, I should open your glove box and it's there. It's in your backpack.
Yeah,
it's
that's
around your house.
And I'm going to tell you that's where to carry your tourniquets is a very subjective topic.
But carry them and have access.
Carry them and have access to them.
Okay.
If we can say, within reason, you can bleed out within 2 to 4 minutes of a massive arterial wound, then as a civilian, if I worked in an office and I had to wear a tie, I'm probably not going to have this on my belt. But I think it's reasonable to say maybe we have a tourniquet in our desk.
Dude, you could totally use this as a tie.
You could.
Look at that
you
right
could.
there. Boom.
I've seen some
totally
bad ties.
patented, trademark, whatever you have to do. Trademark, don't steal it.
But in the past,
next new tourniquet tie.
Well, in the
and
past,
if you hate your life, then you just tighten it down and you're done.
Yeah, it's certainly going to work. But
that's a dumb joke. I should have edited it out.
No. It's good because ties segue into manufactured tourniquets, or austere tourniquets. You're just making them up as you go. I think I went to school, and obviously when I went to school was always the hardest. Everything after me is always easier, right? I went to the last hard class. But the reality of it is, the gold standard in my world is a wooden dowel and a simple cravat. Because I've demonstrated time and time again that with those two tools, I can get hemorrhage control.
Yeah.
Remember, we're trying to replicate those skills with manufactured tourniquets, right? So they're going to perform pretty standard across the board, but they're also going to have similar shortcomings across the board.
Right.
A good medic can make a bad tourniquet work.
Gotcha.
That's why you have to be careful when medics say, well, I can get this tourniquet to work. That's great.
That has more to do with you. It's not because the tourniquet is
not
good.
The tourniquet.
Gotcha.
Where's the data?
Very good.
The data is the great equalizer. So these have been demonstrated in some studies, specifically the CAT, to be upwards of 90-ish% effective in a clinical setting, and as low as 70% effective in a pre-hospital setting. So there's a 20% discrepancy in there. Well, if you go back and look at what that 20% discrepancy is, isn't the tool, it's the operator.
Yeah.
It's generally failure to apply it correctly. And the biggest gotcha I see with these tourniquets is they're designed to be intuitive, so that they're easy to use in extraordinarily stressful circumstances. They're not designed to be intuitive so you can skip the class.
Yeah.
Right? A lot of folks see that, I get it. Yeah, I don't need a class on this. You need a class on it. So most of the time I've seen a soft T or a cat tourniquet fail is, generally speaking, they just weren't put on correctly.
Gotcha.
Most of the time they're not put on tight enough, and as a result, when your first 10 or 15 revolutions of the windlass rod are just taking the slack out. Well, if I did that here, and it may be hard to appreciate on the camera, but certainly from a demonstration standpoint, if I'm just binding up the inner strap for the sake of binding,
that's not doing anything.
It's not doing anything, but you can start to see where you're going to stress the mechanics of the tourniquet. If it's going to break, this is when it's going to break.
Yeah.
So you should have a class. Don't take it for granted that you understand how to do it. Have somebody who's got some experience applying these things. More importantly, experience with these things failing, right? Kind of point out better ways to apply this.
Okay.
This is also a windlass tourniquet, right? So windlass tourniquets have always been around and probably will always be around because they give us, the providers, the ability to increase and decrease the pressure on this tourniquet after the initial application. Now, I'm not going to get too far into the weeds on that, but this gives us the ability to mitigate something called Compartment Syndrome. In some cases, if you're an experienced medic, like my peers on active duty, right, not myself, okay, but my peers on active duty, I have been known in a hurry to just put a tourniquet on just to save time, just to get me out of the bad situation I'm in, knowing I'm just going to take the tourniquet off and put a pressure dressing on.
Yeah.
I could put this on in 20, 30 seconds.
Yeah.
And if you weren't really bleeding that bad, probably even faster.
Yeah.
So boom, put it on, throw it on. I got hemorrhage control. When I get you back and I got some time here, let me put on the dressing that you really need. We can't teach that to laymen.
Yeah.
We got to stick to the rules that are backed up by science, and that's if you put a tourniquet on, leave it on.
Yeah.
No, you know, so the tourniquets in the last year have become somewhat muddy.
When you're in 18 Delta, you get to be like, and I'm going to do whatever I want.
Well, really, any of the SOCM level medics, the Rangers, the PJs, Task Force 168 kids, I say kids, I mean they're grown men. I would trust their medical skills and their operational experience to make those kind of decisions.
Yeah.
You got to remember a Navy corpsman or an Army 68 whiskey are fundamentally glorified EMT basics. I'm down. It's just that if you've got 1,068 whiskeys, I can't get 1,068 whiskeys into the hospital to get the clinical hours they need to maintain that clinical currency.
Yeah.
I just can't.
Yeah.
So sad as it may be, these guys are going to be in the motor pool working on their vehicles and doing Army stuff when everybody else kind of has that ability to go out and maintain those clinical skills.
Yeah.
So in that sense, it is unique to SOF that we have the luxury of the training, time, and finances to get those skills. So I do tend to trust any of the SOCM medics, certainly any of the Navy corpsmen with MARSOC or any of the SEAL corpsmen, any of the SOF guys, and it's not because they're SOF, it's their scope of practice and access to clinical hours after the fact.
Gotcha.
It gets into that third dimension of training and sustainability that's often left out of the TACMed discussion, that being on the committee, you know, I was able to participate in that dialogue. So tourniquet, it's so simple. It's relatively inexpensive. I mean, how much do you spend on gun parts, right? And chances are they're going to cover about 3/4 of the preventable deaths, that you're likely to come across. So, yeah, it's something simple. Throw in your glove box. Instead of having one and carrying it with you everywhere, as a civilian, I tend to have one or two staged everywhere. They're in my car, they're in my kitchen, right? So I'm not trying to keep this everyday carry thing on here.
Yeah.
And another thing I like to point out when it comes to civilians, not tactical guys, is that most civilians aren't going to what I call speed load their gear.
Yeah.
In the military setting or a tactical setting, we expect to have casualties at any moment.
Yeah.
So it makes sense for me to preload this tourniquet right here so I can get it with both hands, like right now. If I work at Starbucks, it's just not something you're going to encounter. So I don't think you're wrong for leaving this in the wrapper, right?
Yeah.
Because if you use a tourniquet in training, it's a training tourniquet from here on out. Every time you use it, you're going to do micro stresses on the fiber. You're going to expose it to UV light. You're going to slowly degrade this thing over time.
Yeah.
In the tactical setting, you're not the ones buying the tourniquet, so when this thing's looking a little ragged, I chuck it and grab a new one.
Yeah.
Right, so it's not a big deal to have it out of the wrapper. But as a civilian, if you're on a budget and you're only going to have 2, 3, 4 tops tourniquets, I don't see the harm in leaving it in the wrapper.
Gotcha.
That makes the argument's always
that makes me
back.
nervous because I'm like, you better pre-rip that package.
Well, that's
get it ready.
Everybody says. In fact, you got something in here, and I'm going to show it in a second. But in fact, I see a lot of guys do this. Is they speed load their stuff because they're taught it has to be done right now.
Yeah.
Well, I just, as a civilian, again, unless you're in the highly unlikely chance where you're a victim of some type of robbery, and again, I say highly, not unreasonable, right?
Yeah.
But unlikely. There just isn't that much stuff we're being exposed to. The numbers don't support it.
Yeah.
Right. So, yeah, we could leave this stuff in its original wrappers, and it's funny because you have this.
Don't
No,
I'm not
I'm
going to
not.
show anyone that.
So the deal is, when you come to my class, you're going to use a lot of pre-used stuff because every one of these is $4 or $5, and it would be hundreds of dollars to give you fresh cuts on everything.
Yeah.
But what I see on the tactical side of the house, if I use these two as an example, is oftentimes people speed load for training a lot of stuff that doesn't make sense. Like if you speed load this, it's no longer clean.
Right.
You want it in this capacity.
Yeah.
Right? So why don't you practice like this?
Yep.
So I tend to, when my students come through the course, they may get a dozen or so iterations of using pre-opened stuff just so they master the hands-on skills. But when it comes to scenario time, they will terminate the day using fresh cuts.
Yeah.
The reason being is they're going to get a sense of what it's actually going to be like to use their gear.
Yeah.
That's just not a cost-effective way for you to train.
Sure.
Fresh cut every time. So we see this in the tourniquet side of the house. When we go back to the tourniquets, all my stuff is speed loaded, but if you're a civilian and you're only buying your kit once every year,
Yeah.
every other year when it expires,
Yeah.
all right, or what are you going to open them up every time and start with these are $20, $30 a pop,
Yeah.
$4 or $5 a pop, you can't afford it.
Yeah.
So leave them in the wrapper.
Sure.
Unless, of course, you're in a line of work where you know you're going to be exposed to injury. I mean, if you work trees and lines and power lines, yeah, by all means do that stuff.
Cool.
But again, if you worked at Starbucks, don't know that I'm going to speed load my tourniquet.
Yep.
So,
So tourniquets, stuff that you would say, hey, if you have a cat, you're good to go. What else?
cat tourniquet is these manufactured tourniquets, the TCCC approved tourniquets. So there's some other ones that have come out this year. I won't speak to them because I haven't had a chance to play with them.
Sure.
Right? But if you had a soft T or a cat, this is pretty much the only tactical item I honestly think you can't really make do on your own. What I mean, this is, and I'm not going to bust out the manufacturer because I love the manufacturer, but the bottom line is this is Cool Guy Gauze. This is Cool Guy Gauze. It's vacuum sealed. It's even got OD green on it. Look, I got the this is Cool Guy Gauze.
Yeah.
There's absolutely no difference between this Cool Guy Gauze and this roller gauze you got at CVS. There just isn't.
Yeah.
Right? So you don't have to spend a lot of money to build your own IFAK. And if you do, again, if you inventory your IFAK and you pack your IFAK using the MARCH acronym, you can supplement stuff.
Can you give us MARCH one more time?
MARCH is massive bleeding or hemorrhage, airway, respiration, circulation, hypothermia, head injury. So I try to have an item for every one of those MARCH categories in my IFAK. All right, so another thing we start to see people get caught up on, and I don't think it's a bad thing, are hemorrhage control agents.
Yes.
Celox is pretty good. I'm a big, to me, in my experience, anything HemCon is absolutely gold standard. It's worked every time I tried to use it, no questions asked. It's a little hard to manage if you're not an experienced medic, so it goes back to what I said before. I'm an experienced medic, so be wary about what I recommend, right? Combat Gauze is what I would consider number 2. It's easy to use. It's fairly consistent. It packs and rolls out just like Curlix, so you're not learning a new tactile skill. Like I know some of the Celox applicators have syringe models and then the pad or various gauze models. I would choose this delivery mechanism over this delivery mechanism because I already have the hands-on skills for this. I got to learn a little new. It's minor. I get it.
Sure.
But these add up. Every time I'm learning a new skill specific to a piece of gear, all of a sudden I go from learning basic MARCH stuff to now I'm relearning everything just to make my gear work.
Yeah, and as well, these are 40-something bucks a pop for this hemostatic agent.
You know why they're expensive? They work.
Yeah.
So,
it sucks if like, here, let me get some training today.
Yeah,
Zip,
and
that cost me
I
40
deal with a
bucks.
lot of families who want the best and they want functionally operational stuff. They want stuff that's been proven to work.
Yeah.
But when you start stacking up the cost, it starts to add up. These work, and I'll use Combat Gauze as an example. Combat Gauze works because you effectively used proper wound packing skills, and that hemostatic agent enhanced that base hemorrhage control skill, right?
Sure. Good.
The mistake I see with these is people time and time again, especially if we've done live tissue in the past. I'm not confirming or denying I've done live tissue, PETA. But the point is, what I've seen with people using hemostatic gauze in the past is they try to get the hemostatic gauze to work. Like, so this didn't work, they'll put another one in, they'll put another one in, and they'll put another one in. It's like, well, sometimes you're not going to get hemorrhage control. You're not. The best you're ever going to do is slow it down and make it control, but you're not going to stop it.
Yeah.
All right, so learn basic skills first, and then stuff like this helps you with those basic skills. But you don't need to look at these as a mandatory item.
Okay.
If you have advanced skills and you're reasonably well rehearsed, I say it's worth the 30, 40 bucks because you got the base skills to make this worth every penny.
Okay.
If you're new into austere medicine, you're new into this stuff, maybe wait for the next go round before you spend the 30, 40 bucks.
But for now, you need your tourniquet and you need your combat gauze. How much combat gauze? Because we've got.
You mean gauze?
Yeah, sorry.
Yeah.
How much gauze do we have? We've this little S roll by North American Rescue. How many of these should be in my IFAK?
Generally, if you get proficient at this, I can use this to pack a wound. I can use this for pressure dressing. I can use this for just good old-fashioned wound care. With a little bit of practice, you can get proficient. I consider 1 gauze with one elastic bandage, one pressure dressing.
Okay.
So generally when I pack an IFAK, I put 2 pressure dressings. That's 2 elastic bandages, 2 gauze in the kit. That gives you a spare in case you're packing a wound and you're not quite as good as you should be. Or you can use it as 2 separate pressure dressings. Right? I got one tourniquet and I got one leg that's bleeding. I got to pick. All right, well, I could put a tourniquet on one and maybe I have enough to manage the other wound.
Yeah.
Optimally, I'd want 2 tourniquets, but the bottom line is any gauze, whether it's just straight up Curlix from CVS and an ACE wrap, good old-fashioned ACE wrap, is 1 pressure dressing. You'll also find I'm not a big fan for that reason of the various what I call cool guy gauzes. Classically, the Israeli bandage has just been it's pervasive. Everybody sees it as, oh, it's the combat gauze. In my world, it's just a really expensive ACE wrap.
Okay.
All right, that's all it is. Because
awesome.
Generally speaking, the pads, I mean, just looking at the picture of this pad, the cinch tight, it's not that it's a bad device. It's that if I can't get into the dimension of the wound, I'm not interested. The pads that come on these things are nothing more than pads. I can't pack with them.
Yeah.
Right? So in that sense, I'm going to pack the wound with gauze, generally speaking, and then I'm just going to use it as an ACE wrap.
What about abdominal stuff?
Sure, abdominal stuff, believe it or not, is not much you can do for an abdominal. I'm not going to get too much in there.
But that could hold the guts all right.
Yeah, I mean, every evisceration I've ever seen has always been like an entrance wound or an exit wound of some kind, and you get a slight, almost like herniation. Right? But one thing I tell folks to have is have at least 2 or 3 of these on you. And I don't use, they have these scissor leashes that you can connect into your body. I usually just have spares for spares. These things are crazy handy. Cut seat belts, cut clothing off, and they cut equipment. I mean, most of the operators I know use them for just GP, but they're good to have. If you have 1, have 2, better to have 3.
Gotcha.
So we talked about M in terms of a pressure dressing and a tourniquet, right? So what comes next is Airway. If you start looking at pathophysiology, which is what's happening in your body after you've sustained an injury or an illness, if you look at pathophysiology relative to airway issues, the cold hard reality of it is, if your patient can't maintain their airway on their own, there's a good chance they're not in a good way.
Yeah.
Right. That is a huge triage tool. If I have to actually manage somebody's airway, and I got multiple patients, that dude is not doing well. I may need to refocus my efforts on a more likely survivor.
Yeah.
I'm not saying either or. I'm just saying airway issues, generally speaking, don't bode well for the patient.
Yeah.
As a result, at the tactical medicine or austere medicine level, there's not much you need to have in your IFAK, because you can get away. Head tilt chin lift, old classic CPR, actually opens the air, positional airways. They're free. They're in your bag now, right?
Yeah.
Just how you position the airway to keep them open. Because if that's not enough, chances are your patient's not going to fare well. Now, there's some stuff we like to put in our IFAKs that, by extension of giving the patient, give us more options. What I mean is like an NPA.
Yeah.
A nasal trumpet. We've all seen these videos of somebody going in. They're fun.
They're not fun.
They're not fun.
They're not fun.
They're horribly uncomfortable.
Yeah, and some of you have a gag reflex. You try to do this stuff. It's not fun at all.
What this allows me to do is to maintain relative openness of your airway if I know I'm going to manipulate you a lot.
Okay.
Right? So if I'm going to drag you, tactical situation, that makes sense. Or if I got to move you in an austere situation, this just kind of gives me that positional airway over time.
Yeah.
But if my patient can't breathe and maintain his airway, or his level of consciousness is so gone I need to intubate him, that's a whole other skill set and discussion. He doesn't need you.
Yeah.
He needs a good paramedic. Not a paramedic, but a good paramedic.
Yeah.
Because that guy needs to have some drugs on board in order for you to really help him out.
Very good.
We also decided to limit ourselves to this particular airway because we don't know yet if the patient has a head injury, and we don't want to overstimulate the gag reflex and put all that pressure into the head. So there's some other airways you could use, but we like to stick to this one.
This is number 28. Is that a good size for me to have gotten, or
it's
should
a
I
good
find something else?
general size, right? It's a good general size. So kids are obviously going to need smaller ones, but there's so many different sizes of children. They actually have something called a Broslow bag. where they color code the length of the kit to the size of all the accoutrement. Well, you're not going to have that. That's a whole kit. So that's generally good to go, because if it's too long, you can cut it.
Yeah.
Now, measure twice, cut once, because once you cut it, you can't add it back on. But even if you do everything right on an NPA, his anatomy, your patient's anatomy still may not work. So it's just a tool, very non-invasive. The other device that I like to see people have in their, if you're going to call it an IFAK, not a bleeder kit. The difference being a bleeder kit is set up for me to just control the urgency of that massive hemorrhage right now.
Yeah.
People like to carry bleeder kits because they know they have some backup med stuff. But when you say IFAK to me, you're implying you have everything to treat a patient. It's a little bit of nuance, and everybody's got their own take on it. But for me, an IFAK is total march. A bleeder kit focuses exclusively on the time-sensitive massive bleeding.
So when I gave you the pouch that kind of goes on my kit, IFAK, this is a bleeder kit. Doesn't have...
It's got some more stuff in it, but classically I would consider this a bleeder kit. We can inventory it, and as long as it's got some aspects of airway and respiration in there, I would be comfortable using it as an IFAK.
Yeah, I think I do. I think I cover March in there.
But there's care under fire.
Yeah.
Right? And then there's tactical field care.
Sure. And this, for me, I've separated stuff into tiers. This is my belt stuff. It's meant to supplement what I have in armor or a Ranger rack or in a belt, a bag. So this is a supplemental thing, but I'm pretty pleased with that.
So I look at it kind of like what you have. I have just enough on me to get me to my backpack. That has just enough in my backpack to get me to my car, and so on, right?
Yeah,
so I don't have to carry 3A bags everywhere I go. It's a tiered response.
Yeah.
When you break down tactical medicine, TCCC, TECC, you got to look at MAR, the first half, care under fire or direct fire care. You're stopping them from dying. That's what you do. You're not repairing anything. You're getting in the way of whatever that lethal physiology is, and you're stopping them from dying. That's all you're doing. Everything you do from CH and evacuation thereon, by and large, is actually focused on the quality of life and quality of care of the patient. So if you understand that, I'm stopping them from dying right here, because that's all I got time to focus on. Versus now that I have some time, I'm going to do some good infection control measures. I'm going to prevent some other things from causing me grief down the road. But that's not the same strategy as I'm going to stop you from dying right now.
Yeah.
Right? So within that care under fire or that IFAK, you should have some type of chest seal. Now, I would just run down to the breacher shed and I would cut off as much hydrogel as I ever wanted because it was on rolls and I had miles and miles of it. Different sizes, different thickness, didn't matter. Rolls of my oyster, I got what I want. However, it turns out that is crazy expensive. So now that I am buying all my own supplies, it's a lot easier and cost-effective for me to buy pre-manufactured chest seals. The exclusive criteria for a pre-manufactured chest seal I look at is, does this thing have hydrogel? I've done tests out here. I've done tests back in the military. But basically, hydrogel is the most likely to stick on your patient throughout the entire ordeal. Okay. Your skin's a profound barrier. The old, I'm just going to tape on a chest seal, yeah, that don't work.
Yeah, I have tape in my medical kit here, just general purpose, but I thought tape down a chest seal.
Yeah,
and
so
Jay told me, he's like, yeah, that's not going to work. It's just tape's not going to stick.
Your skin is a profound barrier. It doesn't want anything to stick to it. So hydrogel was originally designed to stick on EKG pads and everything else. It was designed for the long game. Tape is an issue of convenience, right? So even if we put on an IV, we know tape sucks. That's why they put those cool op sites on there.
They are cool.
But tape's not bad to have, because even if you do everything right, this may still want to slide off. Throwing a little extra tape on there is not going to hurt it. Yeah. But in the urgency of right now, like there's an environmental or tactical problem that could not only hurt my patient but hurt me, I don't have time for tape. Because you got to put so much of it on there in order to make it work. It's not time effective.
Sure.
Anyway, so going to hydrogel, this is the hyphen version. It's actually 2 on a set, because if the bullet must come in, it must come out. It's got decent surface area coverage, right? I always want more, but this is good, right? This is a decent size. It's pretty self-explanatory, but I'll tell you the same thing with hyphen as it goes for the halos. If it's hydrogel, take that extra second to peel it apart slowly, because super glue makes a super mess.
Gotcha.
You guys are in a hurry. They're trying to get this get these wrappers undone in a pass. They stick on it, and then it's done.
There's Hyphen, there's Halo. I've got Hyphens there. What about Fox?
There's several brands out there that use hydrogel.
Okay.
I'm equally satisfied with any of them.
Okay.
Because the fact of the matter is, any of these valves, I'm skeptical that they work as advertised. I don't think they hurt. But these valve chest seals were kind of pushed into the dialogue because nobody was comfortable teaching non-medics how to do a needle in the chest to alleviate the air. Yeah. So we settled on, well, what if I just put a valve in there? It's like, well, I mean, technically, I did it. But I've never really seen the valves work. They clog up. Okay. They get clotted up. Or we imagine these valves on a nice flat pectoral muscle, but what if I'm putting it on the curved, sides? Yeah. You know, that dimension you add to this chest seal now makes a lot of those cease to function. Sure. So, I don't know. I'm sure if you use it in a clinical setting, they work great, but in the field, they always get full of dirt, full of clots, whatever else. Bottom line is, these are relatively inexpensive. You get 2 in a pop. They got instructions on there. Just take your time applying them, because these things, when you stick them on, let me tell you, they ain't coming off, right? And that's what we want. If you've had classes and you're reasonably competent and you've performed under supervision, training or otherwise, having a needle, a large bore catheter is kind of nice. Okay, because this gives me a mechanical ability to remove air from the chest if that valve isn't cutting it. Right now, we're not getting too deep into medicine, but in terms of an item, this isn't a bad thing to have. Just expect that on the civilian side of the house, most folks are going to look at it and be like, oh my God, why do you got a needle? You don't know how to use it. You don't have to, right? You've done the data. Yeah. The military's done the studies. The numbers are there. It is better in every way for me to stick this in your chest and you not need it than for me to be scared to stick this in the chest and you needed it all along.
That's a good word.
Right?
That's a good word.
So, by all means, be reluctant.
Unless you talk to a lawyer.
I know, lawyers ruin everything in medicine.
So hold on, I got a 10 gauge. Yep. Would you recommend a 10 gauge or should I have gotten something different?
This one here is a 14 gauge.
Well, I also have
you also have a 10 gauge
in one of my others.
My experience with 10 gauges is that in our minds, we want to have a larger diameter needle because it'll let more air out faster.
That's why I went and got a 10 gauge.
My experience suggests that when I go to insert this catheter, because it's a needle, it's a catheter over a needle. The needle never has a problem going in. It's just cold steel and sex appeal. It's getting in there. It's the catheter on the 10 gauge that has a habit of bunching up on the way in there. Okay, and it can cause you grief, especially if your patient's dehydrated and his skin's extra thick. Yeah. So stick to a good long 14 gauge needle. These are all 3.25 inch, so you know they're going to be long enough. Turns out you have a lot more fat in there than you think.
I'll work out.
Even all the CrossFit guys have a little more fat in there than they think they do. Bottom line is most needles aren't long enough. The issue isn't the width of the needle, it's the length of the needle. All right, so a good 3.25. Worst case, if I had a 4-inch needle, somebody's going to call BS on this, but I'm just saying. If I stuck this thing all the way to the hilt and I didn't know what I was going to do, you're probably going to be okay. Now, don't pack your aid bags based off that. I'm just saying in most cases, the needles aren't long enough. It's not an issue with the size, it's the issue with the length. So I don't think you need to go to a 10 gauge. You just need to have more than one 14 gauge that is of the appropriate length. Okay, cool. Also, a lot of needles, and this is why North American Rescue's done very well with their ARS, is thanks to HIV and Hep C, transmission risk of accidental needle sticks is, well understood now. So most needles you'll see on an ambulance or in a hospital are what we call safety needles. If you stick the needle in, you can't pull the catheter off without locking the needle out. And that makes it tremendously difficult to perform the needle spike into the chest with the safety needles.
Gotcha.
It's actually harder and more expensive to find the gold school catheters that we learned on way back in the day because they're not what we call AIDS proof. So basically the only people who want them nowadays are guys like us who want to stick them in the chest. Right? Okay. So they're a little harder to find, but they can be found.
There you go. I think that's our IFAK, man.
And I think that's an IFAK. I mean, for me, if you cover M, massive hemorrhage, you're prepared to address airway. If you don't have an NPA, a nasal trumpet in there, I can live with that. Just be prepared to explain to me a positional airway, what your game plan is. And definitely some type of chest seal, right? Cool. Any type of chest seal will do, but my qualifying criteria is that bad mamma jam made out of hydrogel.
Very good. Cool. Guys, Jay Paisley, how can they find you?
Okay, so Jay Paisley, I'm on Instagram, but more importantly, my company, Crisis Application Group, can be found at www.cagmain.com. That's cagmain.com.
Or check below in the description. I'll put a link to his site.
Excellent. And I'm also on Facebook at Crisis Application Group.
Again, description link.
Jay, modern technology.
Yeah,
man.
no kidding. Hey, thanks so much, Jay. Really appreciate it. I learned something, definitely even during this interview, and I learned a lot before we even got on the interview. So train hard, train smart, and get some medical training for sure, guys, and plus up your stuff. See you guys.